Welcome, everyone, and thank you for joining us for the second virtual UMiami Health Talk. Tonight's title is Managing a Breast Cancer Diagnosis During a Pandemic. I will be your moderator for the evening, Ileana Bravo, health journalist. And tonight's UMiami Health Talk is presented by Sylvester Virtual Clinics. Sylvester's expert providers are ready to care for you in our facilities or virtually, wherever you are. We invite you to learn more about the measures we have in place to keep you safe, as well as your appointment scheduling options by visiting sylvester.org. Tonight, we'll hear from Sylvester Comprehensive Cancer Center's Dr. Alyssa Krill-Jackson. Dr. Krill-Jackson will present on how to manage a breast cancer diagnosis in the age of COVID-19. She will explore options around treatment schedules and visit type options, as well as how to recognize emergency symptoms requiring medical attention, immediate attention. Dr. Krill-Jackson will also discuss how to protect your immune system. During the presentation, we're going to poll the audience on questions relevant to the discussion, so please participate, be proactive. Your answers will be anonymous, and they are an important addition to the conversation. Also, we're going to have a Q&A session that takes place at the end of the presentation where you can present your questions. Many of you already have submitted in advance, but don't worry if you haven't, there's still plenty of time. Take a look at the Q&A feature at the bottom of your Zoom screen, and that is where you'll be able to present us questions. And feel free to do them throughout the whole discussion because we'll prepare them for our speaker and we'll address at the end of the presentation. So I'm pleased to announce and introduce you to our presenter, Dr. Alyssa Krill-Jackson. Dr. Jackson is a board-certified hematologist and oncologist at Sylvester Comprehensive Cancer Center. She completed her residency and internship at Brigham and Women's Hospital in internal medicine, her fellowship in medical oncology at Tufts Medical Center, and her hematology oncology fellowship at the University of Miami-Jackson Memorial Hospital. Dr. Krill-Jackson has been treating breast cancer patients in South Florida for over 23 years. And by the way, did you know that Sylvester has 8 locations throughout South Florida, from South Miami-Dade to North Broward? And Dr. Krill-Jackson is working out of Sylvester's beautiful newest location, Sylvester at Aventura. So again, Dr. Krill-Jackson will be presenting on managing a breast cancer diagnosis during a pandemic. And without further ado, Dr. Krill-Jackson, take it away.
Hi there. Thank you all for coming, and feel free to chat questions while we're going through this. I appreciate you all being here. I'm going to talk just briefly about what is COVID-19. I'm sure you all know at this point, but COVID-19 stands for Coronavirus Disease 2019 because it began in Wuhan, China in December 2019. It is a new coronavirus, one we haven't seen before, which is what's causing all these problems. We haven't seen it before. We aren't prepared with vaccines for this before. Now, this virus is a little tricky. It has an incubation period between 2 and 14 days. And that's what's allowed it to spread so quickly around the world, because people can be asymptomatic for up to 14 days while still spreading the virus. And until we got testing in place, it was very hard to detect who had the disease. And until we started locking down, it spread easily. Now, it was called a pandemic by the World Health Organization starting in March of this year. So what are the symptoms of COVID-19? The symptoms are cough, sore throat, difficulty breathing. All of these mimic the common cold. All of these can mimic influenza or pneumonia. It can also cause muscle aches, fatigue, and gastrointestinal symptoms such as diarrhea. One relatively unique symptom that we see with COVID-19 is the loss of smell and taste. Should you have any constellation of these findings, especially if you have loss of smell and taste, you should certainly get tested for it. And if you test positive, you should self-isolate so you don't pass this on to other people. If you have cough, fever, difficulty breathing, this is something, again, you should self-isolate and see if you can get yourself tested. So how do we test for COVID-19? We test for COVID-19 predominantly through what we call antigen tests. So antigen tests test for the actual active virus. They test for the viral RNA. So a swab is placed in the nose, way in the back of the nose. And we swab for the active RNA. We test it with a test called a PCR. And if it's positive, it means that somebody has active infection. They can pass it to other people at that time. Now, the other tests you may have heard about in the news are antibody tests. So an antibody is the body's response to an infection. An antibody is what the body makes to go and kill a virus or to kill a bacterial that's invading the body. And it can indicate present or past infection. So it may indicate some amount of immunity, although we're not 100% sure that people will have complete immunity if they have COVID-19 antibodies due to exposure. Testing for antibodies can also tell us what percent of the population has been exposed. So for instance, in a University of Miami study of random people in Dade County, we found that 6% of patients had COVID-19 antibodies, indicating that about 6% of people had been infected with this. Now, the antibody tests we have are not completely accurate. So there are false positives and false negatives. So we can't 100% rely on these antibody tests. But the antigen tests, although they have a false positive, if somebody gets one or more tests, usually we can detect the virus if they have active disease. So how does COVID-19 pandemic impact our cancer patients? We know that treatment for cancer can suppress the immune system. So of course we worry that our patients may be more susceptible to the disease or more susceptible to severe disease. We know that chemotherapy and targeted therapy can often suppress the immune system. And immunotherapy, although it's increasing the immune system, can also predispose our patients to severe disease. We know that cancer can affect our organ functions. It can affect the kidney function or the lung function or tumor in the lung. And these may place our patients at higher risk for severe disease. Also, one very important thing is that side effects from cancer therapy can be mistaken for COVID-19 symptoms. So diarrhea is a common symptom of chemotherapy, but it's also a symptom of COVID-19. Pneumonitis or inflammation in the lung is something that we see as a side effect of many of our therapies. And it's very, very important to differentiate this from COVID-19 because pneumonitis from a drug needs to be treated differently than COVID-19 or any viral infection.
Okay, we're ready for our first poll question, and it's so nice to see so many of you jumping on to our Zoom call here. The question is, on your screen, have you either tested positive for or believe you've been infected with COVID-19? All of you in the audience out there are seeing it on your screens now. Have you tested positive or think you may have been infected with COVID-19? It's a yes or no question for our first poll question. And a whopping 97%, Dr. Jackson, say no. 3% believe yes.
Okay, well, I'm glad you're all staying safe out there. That's terrific. We do know that some people have the virus without knowing it because a lot of people are asymptomatic, but clearly we want to protect our patients and our healthcare workers, so it's great that you're all taking care of yourself. All right, so how did this pandemic initially affect cancer care? Because of course we appear to have moved beyond the first surge, but when the first surge came and we started canceling things, we ended up canceling screening exams and mammograms for our patients. We canceled elective and non-urgent surgeries. We delayed non-urgent radiation. We were of course worried about the effect of the virus on our cancer patients. Sadly for us, our clinical trials were often on hold. So national organizations that had very important national trials looking at new regimens for our patients, new drugs for our patients, a lot of these trials were put on hold. So our patients could not benefit from them. And in fact, nationwide, the number of patients going on to clinical trials plummeted in March and April. The other thing is the second epidemic. The second epidemic was people avoiding being treated for illnesses that they had, heart attacks, cancers, other things, because they were afraid of coming in the hospital. You know, we don't know how many people may have died or become very ill because they were afraid to come in the hospital. I've heard stories of patients who had appendicitis, but because they were afraid to come in the hospital, stayed home until their appendix ruptured. So we want to avoid patients staying home and having a second epidemic of other health issues. So what are the consequences of these actions that we took to decrease exposure of our patients? Well, there was delay in new diagnoses. We didn't do screening mammograms for about 2 months, so we expect that we may get many more cases of breast cancer in the next few months from patients who were not able to get mammograms for 2 months. That may portend a possible worse prognosis of the cancer. We hope not, but anybody who had to put off their mammogram, we hope is going now so that we don't see worse prognoses. Again, patients avoid necessary care. I have patients who are afraid to come in the office. Primary care doctors have patients who are afraid to come in, and we're afraid that people may not take care of their health problems. Again, delay in our research priorities, and we also worry significantly that our cancer patients are more at risk for harm from COVID-19. So this was a study done in China during the epidemic in China. And what you can see here, I hope you can see my cursor, is on the left of this graph here. This is the incidence of severe disease in patients from 0 to 80% here on this graph. And patients without cancer had about under 10% chance of ICU or death, and slightly more, 15% of severe disease. In survivors of cancer, you can see it's more than double that who had a severe disease. And in patients with active cancer, again, their risk of having severe disease was higher. If you look at the graph on the right, what you can see, again, is this is probability of severe disease. And this blue line here, the teal line, shows patients without cancer. So they had about a 10% chance, 10% or less chance of having severe disease. But this green line, up to 30% chance of having severe disease in patients who have cancer. So we know that our cancer patients are more prone to having severe disease if they catch COVID-19. So there was a study done in the United States, and Sylvester was one of the centers at this study. And it basically was a registry of all patients in these multiple centers who were hospitalized with COVID-19 who had cancer. And what they found was that patients with cancer or a history of cancer had increased mortality, about 13%, which is about double the mortality that they saw in patients who did not have COVID-19. Now, the patients who were at higher risk were the older patients. Patients under 65, even in our cancer patients, only had a 6% mortality, and those over 75 much higher. The other high-risk groups were patients who had active cancer that was not responding to their treatment. Men did worse than women. People who had many other conditions, such as hypertension or obesity or diabetes or were smokers, they did worse. And people who were in poor general health did worse. Interestingly, patients who got hydroxychloroquine, azithromycin, or especially the combination did far worse than the patients who didn't. So, you know, the early reports on these drugs do not appear to be accurate. It appears that, at least in our cancer patient registry, that patients who got these drugs did worse. Other treatment factors in our patients portended a worse prognosis. For patients who were getting steroids, for instance, and we give steroids quite frequently. Most of our patients will get steroids before every chemotherapy in the IV to help decrease nausea. So patients getting steroids did worse. And patients on active chemotherapy in the lung cancer group or patients who had lung tumors, they tended to do worse as well. The good news, though, is that younger cancer patients, patients with fewer illnesses outside of their cancer, and non-smokers generally had a good prognosis if they got COVID-19, not that different than people in the general population. And in this study, at least in this study, there was really no interaction between recent surgery or current treatment and mortality. So basically, we think if we are cautious and our patients self-isolate, that we can continue to safely treat our patients with the medicine they need to kill their cancer.
Great. So let's move on to a poll question that's important sort of to profile the audience. Who's out there? Have you or someone you care about been diagnosed with breast cancer? Yes or no? Have you or someone you care about been diagnosed with breast cancer? And as a reminder, please remember to send your questions to us using the Q&A feature at the bottom of your screen there. You see that little thought bubbles that are Q&A. That's where you can submit your questions for us to consider during our presentation. So in the meantime, we are waiting to see, have you or someone you care about been diagnosed with breast cancer? And 86%, Dr. Krill Jackson, say yes, 14% no.
All right, well, that's interesting. I think, our breast cancer population is a very active group in terms of trying to care for their health and learning new things. So I'm very gratified they're tuning in to learn more. So at the height of the pandemic, many of our national and international cancer societies quickly got together and made guidelines for us to use in terms of what we should be doing and what we shouldn't be doing during the height of the pandemic to keep our patients safe. Because of course we did not want our patients to risk becoming sick, being infected with the coronavirus by coming in for treatments if they weren't 100% necessary, but we didn't want important therapy to be delayed and put our patients at risk for their cancer. So basically, high priority, they made a high priority care criteria where patients needed urgent care. And we would continue to do this throughout the height of the pandemic. Intermediate priority were situations that did not require immediate treatment, but couldn't be put off for too long. So an example of an urgent priority would be somebody with a breast abscess that needed immediate treatment. Somebody with a HER2 positive or triple negative breast cancer that we really couldn't delay chemotherapy because the cancer would grow. An intermediate priority, for instance, would be somebody with an estrogen sensitive breast cancer who we could give some hormonal therapy, a pill to, and put off their surgery for a while. And low priority patients or diseases could be put off very safely without harm to them until the situation was much safer. So we have resumed care to all of our patients at Sylvester. We are not putting off therapies anymore at this point, but I want to go through what care was never delayed. So we never delayed curative or life-extending chemotherapy, targeted therapy, or endocrine therapy. We continue to give that through the pandemic and safely. I have not seen any of my patients have increased problems, increased risk of COVID. I haven't had any patients diagnosed with COVID, although they're getting chemotherapy. We continued patients on clinical trials. Now, again, we did not register a lot of new patients during the height of the pandemic, but patients who were getting therapy on clinical trials continued on these clinical trials during the pandemic. We continued surgery for urgent complications or surgery for breast cancer during pregnancy. We continued surgery for patients who had just finished their chemo and could not wait long for their surgery. And we continued to give emergency radiation for people who had a lot of pain or had a brain metastasis, or again, had finished their therapy and needed to get the radiation at that time without much delay. What did we delay? We delayed follow-up imaging, a CAT scan that could be done at 3 months instead of 2 months, we might delay. We delayed bone densities and heart test echocardiograms that were just done for the purpose of monitoring. We delayed bone modifying agents like Zometa or Xgeva that would not affect our patients' ultimate prognosis. We delayed low risk breast surgery or any procedures that could be safely put off by giving the patient some anti-estrogen hormonal therapy.
So leading us to what you at the university delayed versus what people have delayed. Here's the question. The poll question is, have you or someone you know had to delay treatment or follow-up appointments for breast cancer due to the coronavirus pandemic? Yes or no? So have you or someone you know had to delay treatment or follow-up appointments for breast cancer due to the coronavirus pandemic? And Dr. Krill-Jackson, this will be interesting to see, you know, just motivated by fear, obviously, whether they went ahead and did this. And the no's are 74% no, they did not delay treatment or follow-up appointments, but 26% indeed did.
Well, I hope those people who delay their treatment were doing it on the advice of their doctor, because again, you know, we did not want people who felt a mass in their breast to delay getting evaluated. We didn't want somebody who had chest pain to stay home and hope it went away. But things that could safely be put off, we did recommend patients put off, and we were involved in our patients' decisions to do that. So I hope you had doctor's advice to do that. Okay, so patients have been coming in our office throughout the pandemic, but they worry, what do I do if I have a side effect? What if it's a Friday night? What if it's a Sunday? What do I do if I have a side effect? So we've been educating our patients about the symptoms that require immediate attention. You know, if you have a swollen, painful calf, that might indicate a DVT. If you have fever, that could indicate a severe infection from maybe your white blood cell count being low due to chemotherapy. Shortness of breath or chest pain. Again, these are symptoms that could be due to coronavirus, but can also be due to our chemotherapies or anemia due to chemotherapy. So we tell our patients to call us, but we tell them don't be afraid to go to the ER or urgent care or Sylvester's day clinic if you have these side effects. It is more important to take care of a severe side effect than to avoid going to the hospital. We have procedures in place in the hospital to make sure that patients coming there not with coronavirus are away from coronavirus patients and are safe. You have to make sure that the provider in the urgent care or ER knows what medicines you're on. Pneumonitis from immune therapies or certain antibody drug conjugates like Enhertu, which is one of our new drugs for HER2-positive cancer, can have similar symptoms to COVID. And we need to be involved if our patients are in the hospital with those symptoms. The treatment is very, very different. And we, of course, want our patients to continue all their medicines unless you're advised by your doctor to stop them. Hormonal therapy, anti-estrogens like tamoxifen, anastrozole, letrozole, they will not affect your immune system, and they will not affect whether or not you have severe disease should you catch coronavirus. So what are we doing to keep our offices safe? So right here you can see a picture of our beautiful new Aventura office. You can see that it's well spaced out. Our staff are wearing masks. Not all the chairs in the waiting room are available so that patients don't sit near each other. We're trying to minimize the number of patients waiting, and we're doing that by having no visitors accompanying patients into our office. And that's a little sad for our patients not to have company when they're in the office and getting chemotherapy, but we're always willing to use technology to bring another patient, to bring a patient's family member in the room with us to join in the conversation. At some of our offices, people are waiting in their cars and being called when it's time to come up to keep the waiting room from being crowded and allow for social distancing. We're screening every patient for symptoms before they come in the office. And if they have symptoms, we are evaluating them before they come in the office. We're trying to protect our patients as well as our staff. Every patient who comes in is dispensed a level 3 surgical mask. So even if you come in with your own mask, we are dispensing a surgical mask that you need to wear above your mask. And that is to protect our patients as well as to protect, again, other patients and the staff. And before patients start getting their chemotherapy or treatments in our treatment unit, we're doing COVID nasal swabs to make sure that they don't have active disease. And the picture of me up there is how I look in the office every day seeing my patients. So usually I'm wearing a mask and often wearing a shield too when I go into the treatment area. All right, Ileana.
Right, so it's the perfect question. Would you feel comfortable out there coming in to see your oncologist knowing the precautions we just discussed were in place to protect you? Dr. Krill-Jackson just laid it all out, all the extra precautions they're taking. Now, would you feel comfortable coming in to see your oncologist knowing this? It's a yes or no question. %, Dr. Krill-Jackson said yes.
I guess we're doing our job fairly well. I will tell you that I feel very comfortable having even our most immunosuppressed patients coming in our office. It has, we've worked very, very hard to make sure that our patients are exposed to as few people as possible. And again, I think for our sick patients, it is very important that they continue their monitoring and care. So I'm going to talk a little bit about what we've done for particular types of breast cancer. So for hormone receptor positive breast cancer, the usual thing we do is do surgery right away. And then afterwards, we decide what patients need. However, we reversed that a little bit in the pandemic. So we've sent off tests called genomic tests on the biopsy specimen as opposed to waiting for surgery and the pathology from the surgery. So the genomic tests, what they can tell us is this a high-risk cancer that's going to need chemotherapy? Or is this a low-risk cancer that could do well in just hormonal therapy? So you can see on the right this report of a test called an Oncotype. And this patient's breast tumor had a score of 32, which is a high score. That patient, we would be counseling that they should get chemotherapy. So when we didn't want to do surgeries, we would give them chemotherapy before their surgery. However, if they had a low score, like a 15, we would tell them that they have a very good prognosis. They only need anti-estrogen hormonal therapy, and we'd put them on hormonal therapy before surgery. And that will help shrink the tumor, and then we can do surgery at a safer time. Now, you know, although the order is different, it's sort of like having a banquet. You know, if you want to eat your dessert first and your meal second, you still get all the same number of calories and food in your stomach. It's just a different order. So basically, this is sort of the same thing. We know that it's safe to give hormonal therapy before surgery. And actually, in Europe and in older patients, it's a very common thing to do. We can give therapy for up to 4 to 6 months, and we can see the tumor shrink substantially, which actually can make the surgery easier. So that is something that we have been doing more often now during the COVID pandemic to help decrease patients in the hospital. Now, in higher risk breast cancers that had a high Oncotype score or genomic score, for instance, or cancers that are triple negative or HER2 positive, which are more aggressive type of cancers, we routinely do chemotherapy before surgery. We actually know from several trials done many years ago that there's an equivalent prognosis for patients if they got chemo before surgery or after. And some women even showed benefit of having the chemotherapy first. It really is a routine thing we do now because in triple negative and HER2 positive disease, we can assess how patients respond to the chemotherapy. So if we get to surgery and they take out the tumor and there's no live tumor cells left, we know those patients have a very, very good prognosis. If there are tumor cells left, we actually have data that if we give them another agent after surgery, we can improve their prognosis. So in fact, doing chemotherapy before surgery actually benefits our patients in terms of finding out who needs more than our standard therapy. And so we've been doing this and maybe even expanding it. in the height of the pandemic. Of course, we're back to doing surgery on a pretty routine basis now, but we're still catching up from patients who were delayed during the pandemic. Now, in DCIS, which is a precancer, again, we can use hormonal therapy to shrink the tumor up and wait for surgery. Again, this allowed us to delay surgery for our patients till a time that it was much safer to be in the hospital. All right. The biggest question I get from my patients is, when is my immune system going to recover from the chemotherapy? In fact, I've had patients who had chemo 15 years ago email me and ask me, is my immune system normal? And what I have to tell them for the most part is, yes, it should be normal at this point. But it does take a while for our immune systems to get back to normal. So our neutrophils are the white cells that fight bacterial infections. And these recover within a few weeks. So these are the cells that we're checking every time you're getting chemotherapy and making sure that they're high enough for you to get chemotherapy that day. And they recover very quickly. However, our lymphocytes are cells that can take a little bit longer to recover. So B cells are cells that make antibodies against bacteria and viruses. And CD4 T cells also protect against viruses and also fungal infections. And these can take a long time to recover. So I don't hope you can see my cursor. If you look at graph A on the top, what you can see here in this first bar is where patients' B cells were prior to chemotherapy. 2 weeks after they finish chemotherapy, you can see their B cells are quite low. But at 3 months, they're coming up, 6 months, they're coming up, and at 9 months, they're almost on average back to the normal level on average. The CD4 cells as well. This is the CD4 cells before somebody starts therapy at 2 weeks after, and they're climbing slowly. By 9 months, we're up to a normal level, albeit not quite as high as we started at. Now, before coronavirus, we really didn't see patients getting more severe infections in the months after chemotherapy. However, we don't know with coronavirus if patients might be more at risk for severe infections in the months after chemotherapy. So I'm cautioning my patients that they may be still somewhat immunosuppressed for several months after their chemotherapy. So they should really take seriously social isolating, washing their hands, avoiding situations with large crowds, and avoiding people who are sick. Now this I found very, very interesting. This is a study about cigarette use and immune system recovery after chemotherapy. And what you can see here is that patients that smoke are much slower to recover their B cells and T cells. So if you look up here where it says B cells, you can see pre-chemotherapy. The white bar is patients who don't smoke, and the dark bar is patients who do smoke. And you can see that they have about the same number of B cells on average before chemotherapy, and about the same 2 weeks after chemotherapy. But look at what happens 3, 6, and 9 months after chemotherapy. The smokers have a much, much more delayed recovery of their B cells than the non-smokers do. So this is a really, really, really good argument for quitting smoking, even if you're on chemotherapy. We also know that smokers do much worse if they get COVID, probably due to lung damage from the cigarettes. So hopefully, if you're a smoker, we can convince you to quit with this data. All right, so how are we making therapy safer for our patients? So, I've been discussing this a lot with my patients every day in clinic. So patients who have advanced cancer, sometimes we're discussing putting patients on oral treatments instead of IV treatments, so they have to come into the office less. So if that's an option, you can discuss that with your doctor about changing that. Sometimes we'll talk about putting patients on hormonal therapy as opposed to an immunosuppressive chemotherapy. So I have one patient, for instance, who came in this week whose cancer was getting a little worse on her therapy, but I didn't want to start her on chemotherapy, number one, because of COVID, number two, because she was feeling relatively well. So instead of chemotherapy, we tried another hormonal therapy that was maybe more unusual than we've done in the past. And she's actually doing great on it and doesn't have to come in very often. You should talk to your doctor about minimizing steroids. So there are medicines that we give for breast cancer, like Taxol, that require a lot of steroids before we give it to prevent immune reactions. But there's another formulation of Taxol called Abraxane, which actually doesn't require pre-medication with steroids. So I've actually switched patients from Taxol to Abraxane because they're the same medicine, just one causes allergic reaction and needs steroids. We can also change our treatment schedules to keep patients from coming in so often. So instead of getting a weekly chemotherapy, patients can get an every 2 or 3 week chemotherapy, which keeps them home, you know, and away from other people and away from the office more. In terms of appointments, we're implementing precautions in the clinic, as we showed before. We're doing telemedicine visits, but we do not want to delay urgent care. And then we tell our patients who are getting chemotherapy that they really should self-isolate during treatment. Keep their bubble of people that they interact with very small. Keep away from crowds, good hand washing, wear masks if they have to go out, and we're telling them to stop smoking. So how do you protect yourself? The bottom line, in my opinion, is don't smoke. While you're on chemotherapy, avoid public situations, self-isolate. Again, talk to your doctor about ways that your chemotherapy could be less immunosuppressive, if there's substitutes, if there's, we can minimize steroids. And then again, to avoid high-risk situations for several months after your chemotherapy, as you may be at more risk. But years later, I think your immune system has recovered and you should be safe at that point in time.
Okay, so that leads us to the final survey question, and that is, did you or anyone you know come to Sylvester virtual clinics to consult a provider, and what was your experience? Yes, it was a good experience. Yes, it was not a good experience, so we have a double positive. And no one I know has used it. So have you or someone you know used a Sylvester virtual clinic visit to see a provider, and how was the experience? Yes, good. Yes, not good experience, and no, have not used it. Okay, 62% said, yes, it was a good experience. 3% said it was not a good experience, and 34% did not use the virtual clinics. So that's interesting, isn't it, Dr. Krill-Jackson?
It is, and I'll tell you, I think that mirrors my experience. I think patients have been actually very pleased with the virtual clinics, and I'll tell you that I have been pleased with them too. I don't think it can replace all visits, and I think as providers, we found it was very difficult to do virtual visits back to back to back all day long, but I felt that it was really much more positive experience than I was actually expecting. And I feel so fortunate that most patients and most people have the ability, the technology to be able to do this, because 10 years ago, this could have been a much worse situation without this kind of technology. So telehealth visits in patients who are getting treatment allows us to evaluate symptoms and has been actually shown to improve symptom control and psychological distress. I'll tell you that on Monday this week, I had 2 patients call with symptoms, and they don't live very near to my office, and we didn't want to have them come in if they didn't need to. One had sores in their mouth, and we needed to tell whether this was an infection in her mouth or just an ulcer in the mouth from the chemotherapy. And we quickly scheduled a telehealth visit. She shone a flashlight in her mouth, and I was able to tell what it was and send in a prescription to her pharmacy. The other had some pain, and she was able to show me on her body where the pain was because I could see her on camera, as opposed to trying to guess on a telephone call what she was complaining about. And we were able to solve their issues very quickly without having to have them come in the office. So I think it's been a real bonus. And prior to this pandemic, Medicare and other insurers would not pay for telehealth visits. And that's one of the reasons that we had not been doing them. But now I think it's here to stay. I think we've all found how important it can be to our patients to go through side effects and treatments. It also allows our UHealth patients to see the doctor of their choice, but maybe get their chemo closer to home. So I have a patient, I was in Sylvester, Maine Clinic today, and I have a patient who lives south in Kendall, and there's a Kendall Center right close to her house. So what she did is she went to the center, she got on her cell phone, and we had a virtual visit. She had her blood drawn at Kendall. We had a virtual visit. We talked, we discussed her blood counts, her side effects. I prescribed her chemo, and she got it right there in Kendall. So she didn't have to drive all the way up to the Sylvester, Maine campus to see me to get her chemotherapy. And that made her life much easier, especially on chemotherapy. Second opinions. Patients have easier access to second opinions. I can see a patient who lives in Key West. I can get her medical records. I can get, the films and look at them and do a consultation online for that patient while I see the patient and talk to the patient. And they don't have to travel 3 hours. Patients here who want to have a visit, with a specialist in Boston or New York can arrange that as well. The other thing is nice is it allows distant family to be part of the conversation. So I have patients who have children that live in New York, and they'll be online, and then their child from out of town pops on the visit. We can all see each other and all talk to each other. And I think that's really been helpful for our patients and their family members. They can all hear what I have to say, even if they're not in the room with us. For follow-up, so a lot of my patients will say, why should I make a follow-up visit if I can't get a breast exam? Well, breast exams are very important, but there's other things that are important too in the follow-up of breast cancer. So this is what we see. This picture is me and actually my nurse practitioner who's often participating in our telehealth visits. And there's usually a third box where the patient is, or a fourth box where the patient's family member is. So if I can't do a breast exam, what can I do? Well, sometimes people can show me things online that they're worried about, and we can evaluate them. A lot of our job is discussing physical and emotional symptoms and side effect management. That's been the big thing for my patients, and it's the big thing even when I can do a breast exam, discussing what kind of side effects they're having from the therapy, hot flashes, vaginal symptoms, psychosocial issues, musculoskeletal symptoms. And we can evaluate those easily online with a conversation and change medications. And it's very helpful to see a patient as opposed to just talking on the phone, which I find is much harder for evaluating patients. We can schedule screening exams, refill medications, and discuss updates on the newest research in breast cancer. The other thing that's been wonderful, I think, so the silver lining to this pandemic is that we've been able to offer virtual psychosocial services to our patients. So like a talk like this that I'm giving right now, normally we would have several people in a room because only some people could travel to the location at the time. And in Miami, there's traffic. And so, an educational event would be seen by a few people, but not so many. So with virtual Zoom services, many people can hear a talk. And I've actually found that wonderful during this pandemic to be able to go to lectures that I normally wouldn't be able to because I wasn't on the same campus that the lecture was taking place on. Our psychosocial department is doing virtual support groups. So no matter what, your work schedule, where you work, where the group is, you can participate online. We actually have virtual pet therapy, virtual music therapy, drumming sessions, dance therapy, yoga and exercise classes. There's virtual meditation teaching sessions. And again, you can have a personal visit with your psychologist or psychiatrist, a consultation for sexual therapy with one of our psychologists. So there's a lot that we can do, a nutrition consult, and I think it's actually allowing our psychosocial services to be used by more people than prior to the pandemic. And we have all the services online, and I urge you to consider looking at these services and taking part in them. They're free for our patients, and you just zoom in when they're online. So anyhow, I want to thank you for coming to this talk, and I want to thank my staff. So on the left-hand side here, what you can see is many of the staff that work in our office, our nurses, you know, from our nurses to our secretaries to the people who clean our office. It is a partnership to keep our office safe and healthy for all of our patients. And this is on the other side, me and my nurse practitioner. And thank you again for coming to this talk. I'm happy to take questions, and I hope you feel safe coming in to visit us. We think it's a safe environment. Thank you.
Thank you so much, Dr. Krill-Jackson. I mean, such a soothing and positive voice that you've given this tonight, which is important for people who are frightened and concerned, and understandably so. So we are indeed ready to begin the Q&A session, and we're going to get as many in as we possibly can. So on this point, I'd like for you to reiterate, one of the questions is on virtual telemedicine. Can the visit really be helpful if I cannot get a physical breast exam?
You know, again, you know, I was a little skeptical when I started doing the virtual telehealth, but I found it to be actually a really, really good experience for my patients. They have really responded positively. There are some patients who don't want a visit if they can't have a breast exam, but I found most of them find it's very helpful to discuss, you know, if they're having problems with their medication, when should they get their mammograms, when should they come in for the breast exam, what kind of, you know, symptoms and side effect management. So, you know, I found it's been a very, very positive experience for most of my patients. I think a lot of people like the reassurance of going to their doctor, even just talking to the doctor, even if they can't get an exam. And again, at this point in time, we are seeing patients in person. And so if people feel comfortable, they certainly can come in for their breast exam at this point.
So this question from Debbie, I know you alluded to this, but again, let's talk about this. Do cancer survivors have a higher chance of contracting the coronavirus? And what are the precautions to prevent it? I think you've talked about it, but again, let's bring home that point. Are they the same as the general population?
I think patients I don't think you're at a higher risk of contracting the virus. I think contracting the virus is a matter of the precautions that you take. But having severe disease is obviously higher in somebody who's actively fighting an active cancer. But several years later, it appears that from the studies that I showed, actually, when they looked at the breast cancer population who'd had cancer in the past did not have a higher chance of dying of coronavirus. I think that's different than patients who have, for instance, lung cancer and damage to their lungs. So I think it's reassuring. I think if you're, you know, more than 6 to 9 months after your chemotherapy and you're in good health and don't have a lot of other medical illnesses, that your risk for dying or having severe disease if you contract coronavirus is not higher than the general population.
Okay. And this anonymous question, how long after my last treatment is my immune system compromised? Do some treatments put me at higher risk than others?
Well, some treatments do put you at higher risk. So, you know, we know hormonal therapies, anti-estrogens, will not put you at higher risk. There's some therapies that we use for other types of cancers, like especially lymphomas or leukemias, that can make people very immune suppressed for long periods of time. I think our patients who get standard chemotherapy for breast cancer probably have some immune suppression for a number of months, but I don't know if that puts them at markedly higher risk for coronavirus, severe disease. So I would say, you know, if your blood counts have recovered, you're 3 to 6 months post-therapy, I think your immune system is likely good enough that you're not going to be at extreme high risk for complications should you contract the virus.
Okay, here's a question that just came in from our Q&A chat. Did you say all patients are swabbed for COVID?
All patients who are going to get their first treatment in our treatment rooms get a nasal swab to make sure they don't have the virus, you know, because we know that a lot of people are asymptomatic when they have the virus. So we want to make sure before they're coming in to get immune suppressive chemotherapy and before they're coming in to spend long periods of time in our office with our nurses and doctors and staff, that they are healthy.
And again, along those lines, here's an anonymous attendee who says, for those of us who remain concerned about exposure and may continue to be isolating to some extent, how do we handle people with a lot of exposure who want to visit us? I think this is on top of everyone's mind, but not a cancer survivor. Is it safe for them to come into our house for dinner, for a cup of coffee?
Again, I think it depends on what therapy you're actually getting. And what your friends who want to come over have been doing. If you have, if you're on chemotherapy, we're asking our patients not to see other people, you know, not to go into an office, not to see people out of their immediate family bubble if they're actively getting chemotherapy. So, you know, you can certainly tell your friends or family members that want to come over that your doctor has told them that they should not interact with other people outside of their family while they're on therapy. You know, afterwards, when your immune system is better, then I think we have to, you know, follow the CDC guidance, which is, you know, people outside of your family circle to, you know, socially distance, be at least 6 feet apart, outdoors, if you can, if you're seeing other people, wear a mask if you can't stay far away from other people. But while on active chemotherapy, I think it's best to do virtual visits with friends and family.
Yeah, I think that as more communities open, this is a challenge. And if you are a patient, I think you have to take matters into your own hand. Here's a question from Daniela. This is very specific now. She says, please tell us about pseudoangiomatosa stromal hyperplasia, PASH, and the connection, if there's any.
There should not be any connection. That is not a cancer. That's a finding that we find in the breast on some breast biopsies, but there is no link to any changes with coronavirus, any more severe infection. It should not suppress anybody's immune system, and it is not related at all to this.
How about this question? Is a lack of estrogen due to treatment with letrozole a risk factor for COVID-19?
No, hormonal therapy should not be a risk factor for severe COVID-19. Now, again, you know, contracting COVID-19 is about, you know, who you're interacting with, hand washing, touching your face. But severe disease is what we worry about if our patients are more immune suppressed. And hormonal therapy like letrozole should not increase somebody's risk of having more severe complications should they contract the virus.
All right, here's a question from a breast cancer survivor. She says, I have my annual checkup coming up, also my mammogram, ultrasound, and MRI. Should I use telemedicine or go in person?
Well, I think that depends on how long you are after your diagnosis, what your age is. But I think at this point in time, again, you know, I can't tell you for every office in every city in this country, but I will tell you at Sylvester that we've done a very good job keeping our patients safe, making our offices not crowded so our patients are not exposed to a lot of people. I think you can feel comfortable coming in and getting an exam and getting your mammogram and ultrasound at this time.
And I loved that screen that you put up about the psychosocial programs, from the yoga to pet therapy and all that. And this is an anonymous question, says, what advice do you have for controlling stress?
Oh my goodness. I think it's very hard. I have a little thing on my desk that says anxiety is like a rocking chair. It will give you something to do, but it won't get you anywhere. So stress is hard. I think that we have to be grateful for the things that we have, and that is known to help stress. But I think, you know, participating in activities. And again, nowadays, a lot of these activities are virtual. A lot of people are feeling stressed. They're worried. They're lonelier. And that's why we have all these virtual activities. I think that this can make people feel well. Exercise can help make people feel well, feel better. But again, if you are feeling significant stress, I think I would talk to your doctor about that. Some people may have true depression, and we can help them with medications. We have psychologists that are ready to see our patients virtually, and can help. We have meditation online, but again, exercise, meditation, seeing a psychologist, discussing it with your doctor, and using all these virtual tools we have to connect with people. I think if you take precautions, you should be able to remain safe from the coronavirus, and so I would rely on that and take precautions, and try to use these other techniques to decrease your worry.
Well, here's a nice positive note as we're wrapping up for the evening. This is a patient who says, I'm so appreciative that during this pandemic and quarantine, I had the option to meet Dr. Krill Jackson via telehealth. 60 days after my mastectomy, I'm comforted by the support I've received from all Sylvester providers, and I'm doing well on the hormonal therapy prescribed. Thank you for helping me when I needed it most.
Well, that's wonderful. Thank you. I don't know who that is, but I'm glad you're doing great, and that's why we do what we do. We love, you know, taking care of patients. I love taking care of patients and making patients feel better. So I'm glad that you've had a very good experience.
Thank you so much to all of you in the audience who have stuck with us, you know, zooming in on a Thursday evening. Dr. Krill Jackson, you were magnificent. Thanks for all of your wise words and words of comfort at a time when people need it so much. I remind everyone that June is National Cancer Survivor Month. So what a perfect time to be talking about this. And our program has come to an end. Thank you again to all of you who joined. I hope that we got to all of your questions. We certainly tried. We at Sylvester Cancer Center appreciate your participation. We're here to care for you. I think that we've driven the point home tonight. We invite you to visit sylvester.org to learn more, make a virtual appointment, an in-person appointment with our experts. They're here for you. And we hope you've enjoyed this, and please complete the survey at the end of the talk to give us your feedback, and to furthermore even give us topics of interest to you for future Zoom virtual UHealth talks. Have a great evening, everyone, and please stay safe out there.
Thank you, everyone. Stay safe. Bye-bye.